the Women in Health webinar. This webinar is just to also mark the International Women's Day. We are supposed to start by 10 a.m., but I think most of the participants are joining a little bit late. We have our panelists already in the house, but I think we should just maybe give another 5 minutes for other participants that are running late to come in before we start.
Seminar.
Good morning, and welcome to this morning's webinar on advancing maternal health care through universal health coverage. It's a pleasure to welcome all of you, especially our esteemed panelists. It promises to be a very interesting conversation, and we do know that more people are joining, but we do not want to penalize those that joined in early for those that are going to come in late. My name is Neko Kekaru, and I work at the Enterprise Women's Center, and I'm the director of the Health Management Program, which is a platform this webinar is riding on. And I'd like to say from all of us at EDC that we're excited at this webinar. We're excited because we're going to have more webinars coming up during the year. So for those of us that have logged in, I hope you have your pens and your paper and you're raring to go. So enjoy the webinar. So it's my pleasure now to hand over to Nedu. Nedu is going to read the bios of the panelists. Nedu, over to you.
Okay, thank you very much, Neka. So to do justice to this webinar today, we've lined up a couple of panelists, seasoned directors in different fields that affect the healthcare sector. So I have here Dr. Ngozi Onya. She is the founder of Pilon Memorial Hospital. So Pilon Memorial Hospital is also the only 5-star hospital that is in Nigeria by Safe Care standard, and because of their quality assurance and processes that they try to implement in their hospital. We also have Dr. Frances Ilika. She is the country director of, just a second. Yeah, so she's the country director of Palladium USAID, Health Policy Plus, and I also have Dr. Amina Aminu Dorai, and she's also the country director of Pathfinder International. To drive this conversation today is Dr. Cecilia Abimbola Magbugunje, who is the Chief Medical Director of Massey Children Hospital, Lagos. So to start this webinar, I'll be handing over to the moderator, Dr. Mrs. Cecilia Magbugunje. You have the floor, ma'am.
Thank you very much, Nedu. Thank you, EDC, for allowing me to do this. And welcome to everybody. Welcome to the panelists. Thank you, Dr. Onya, Dr. Ilika, Dr. Aminu Dorai. I mean, your profiles are beautiful, and I don't know whether I need to read them all out, but I think Nedu has done a beautiful summary. But everybody here is very well in tune to be at this, to talk about advancing maternal health care through universal health coverage. So I'll start off by talking briefly about maternal mortality rates, which I still find extremely high. And unfortunately, 34% of the total maternal deaths are shared between India and Nigeria. In Nigeria, the figures are 814 per 100,000 live births, which is unacceptably high. A woman or a girl has a 1 in 22 chance of dying in pregnancy, childbirth, postpartum, or post-abortion. And it talks to access to healthcare, universal healthcare, poverty, and all sorts of other factors, which I believe we'll be touching on today. So I have some questions I'm going to ask, and I'll start with Dr. Ngozi Onya, who happens to be a senior colleague of mine in the pediatric world. I'm very passionate about this because in pediatrics, if the mother is not well, who will look after our dear babies? So a mother has to survive that childbirth process in order to look after the child. So Dr. Onya, are you online? I can't see her picture anywhere. Oh, hello, Dr. Onya, good morning. I'd like us to start by discussing where we are with maternal health in Nigeria. What are the challenges women are facing in Nigeria at the moment in accessing care?
Good morning, everybody, and thank you for inviting me to speak on this webinar. Let me start by making a slight correction to what Nedu said when he introduced me. So we were the first hospital to achieve a level 5 on the safe care quality improvement journey, but Evercare has also achieved a level 5. So we are not the only hospital anymore. We're just the first. That won't change. We're talking about maternal mortality and where we are today, particularly vis-a-vis the SDG, first the MDGs and then the SDGs. I think the first thing I would like to say is what my pastor will often say, that we're not where we should be, but we're not where we used to be. So I looked up the WHO website, and when the SDGs were agreed on in 2000, and maternal mortality was 1,200 per 100,000 live births in the year 2000. The SDGs replaced the MDGs in 2015. And at that time, it had reduced from 1,200 to 978, which was a 32% reduction in maternal mortality. And then from 2015 to 2021, there was a further 16% reduction to 814, which I agree is unacceptably high, but we should encourage ourselves that we are going in the right direction, for which we should be grateful. I think when we talk about access to healthcare, the first thing will be even physical access. The challenges are myriad. One tries not to be like a doomsayer, but the honest truth is that there are lots of challenges. So universal healthcare refers to the ability to access healthcare when you need it without financial hardship. There are many things around that. First, do we have enough healthcare providers in the country? What is happening with the healthcare providers in the country? So the big elephant in the room that still hasn't been addressed is the brain drain. Healthcare providers are living in droves. So we need to do something about that. I was very encouraged when a young lady reached me on LinkedIn and introduced her services to me. She had a private health technology school, for want of a better way to describe it. So she's training like medical assistants, nursing assistants, and phlebotomists. So lower level healthcare workers, but at least who have some training. Clearly, this is the way we have to go again. And it reminds me again of our senior colleague, Dr. Mabogunje, Professor Ransom Kuti. We need to start training people at lower levels, even the TBAs. We may need to go back to the TBAs and upskill them and make them able to provide the care that people require. We will need more healthcare centers. So back again to primary healthcare. I just wish we could just bring out Professor Ransom Kuti's playbook and replay it. I think it will solve all our problems. We need to take healthcare down, really down to the level of primary healthcare. We need to empower people who are not about to leave Nigeria for the UK or Canada anytime soon, and train them on the basics of safe delivery of children. I think those are the two major things I can think of. So the training, and then of course, the most important I didn't mention, because the last part of universal healthcare is without financial hardship. We need to find a way to pay for healthcare for those who can't afford it. Health insurance, universal health insurance, is the way forward. So for example, I run a primary health care center, and I think it's a model that is admirable and that should be compared. I mean, should be what's the word now? Copied by others.
Copied,
yeah. So in Delta states, where they have a mandatory health insurance scheme, so there's a primary health care center in one of the most rural, the back of nowhere, where sorry, I shouldn't call it back of nowhere. Somebody might come from there on this call, where we run a primary healthcare center, and it's quite a standard one. We know a lot of politicians go around building primary healthcare centers to commission them and then lock them up and throw the keys away. So Delta State was able to resuscitate quite a few of them, give them out to primary healthcare, to private healthcare providers to run in partnership with Delta State. And so in Amai, in Delta State, we are running a primary healthcare there, and the government pays for the people they call the legacy patients, pregnant women and children. And I'm happy to say, since we started in 2019, we've delivered, well over 100 babies, and we haven't lost any life. These are lives that either of baby or of mother. These are lives that may have been lost had that health center not been present, in that locality. So I think there are various ways we will have to look at things, look out of the box and do things. So that's a very good model that I think should be replicated. The mandatory health and the health insurance in Delta State is 7,000 per annum per individual. That's nothing. 7,000 per annum per individual is what the people can afford, is what we can gift our poor relatives back home. Just take that as a responsibility. Every year I pay for your health insurance. And then they have access to quality healthcare. So once again, kudos to Dr. Kowa and the Delta State health team. Thank you.
Thank you very much. Thank you very much, Dr. Onya. That was nice and comprehensive and has taken us even far beyond where I wanted us to start. But I'll go back a bit again. And Dr. Ilika, you've done a lot of work with reproductive, maternal, and child health over the years. Where do you think we are at the moment, and what are the other challenges that may be facing maternal health in Nigeria at the moment? Yeah, you're on mute. Unmute yourself, Dr. Ilika.
Thank you very much. I'm happy to be able to contribute to this panel of excellent panelists. So Dr. Onya has actually highlighted a lot of the issues that we have with maternal and child health, and also the moderator at the beginning had, set a very good stage with regards to the indices, what the indices are saying, because data doesn't lie, So there are a lot of issues with maternal health in Nigeria. And I'm actually happy that we have this rich panel where you have people with perspectives from the healthcare providers' viewpoint. And then I would actually like to come at this from the health system strengthening or rather health financing viewpoint. So I had my early career in clinical medicine. I was working in hospitals, attending to women, to children. And one of the things that drove me from clinical medicine to policy was the fact that a lot of the women and the children who came to the hospital came at a point where it was too late to save them. So what this means is that there were lots of barriers to women accessing healthcare, quality healthcare when they needed it. So I had to make that decision to either stay at the hospital and attend to the people who could afford to come on time and at the time when they could be saved, or go out there and do something in policy, engage government, you know, and the people that have the power to actually remove these barriers to women accessing care. And that is what I've been doing for the most part of my career. So in trying to interrogate why there's issues, where one of the major things that come out is financial barrier to accessing healthcare. And I'm happy that Dr. Onye actually mentioned about UHC, universal health coverage. You know, when we look at the goals of UHC, universal access, making sure that everybody, wherever they are, can have access to the healthcare that they need when they need it, you know, and promptly enough for it to be effective. Quality of care. So it's not just any type of healthcare, but good quality healthcare that can actually lead to improved outcomes. And then, of course, financial protection. So that let the financial barrier not be there for them to access care, which is for the most part, the issue that we're having in our part of the world, where over 70% of healthcare is paid through out-of-pocket expenditure. What that means is that if a woman needs healthcare and she cannot afford to bring out money from her pocket and pay at the point where she needs that healthcare, she's not going to access that healthcare. What that means is that, you know, she's going to get worse. She could even die as a result of that because she didn't get the prompt care that she needed. And then you also have families selling off property, going into loans and borrowing in order to pay for healthcare, which further pushes people into poverty. And then we have this vicious cycle going on. So financial barriers to accessing healthcare is one big major issue that we have to tackle. And then, of course, the other side of it speaks to when these financial barriers are removed. So I like to call it the demand side and the supply side. So the demand side is these financial barriers that prevent women from accessing healthcare because they don't have money in their pockets to pay for it. Of course, it's a much bigger issue when we begin to look at what are all those social determinants of health. Why don't these women have the money? You know, why can't they pay? What are all those other things that contribute to that? That's a totally different story altogether, but still certainly related to what we're talking about. And then the second aspect of it is the supply side. So even when we remove these financial barriers to women accessing care and they get to the hospital, what do they meet there? Do they meet the quality healthcare that is promised? Do they meet qualified, skilled human resources for health? Do they find the drugs and the equipment that they need? I'm talking about primary health care especially. So for me, I like to address this from a health financing perspective, looking at what are the issues with removing financial barriers to women accessing care. And there are a lot of interventions in place already that I'm sure we'll get the time to talk about later, including the Basic Healthcare Provision Fund, decentralization of health insurance. A lot of states are making progress at different levels and speed. And then, of course, the supply side. Just recently, the National Primary Healthcare Agency, just this, I think about last week, had this PHC summit, where they're thinking about reimagining primary healthcare, how to make sure that people can actually access good quality healthcare at the primary healthcare level, we should ideally be the first place that people need to access care. So we need to fix the demand side as well as also fix the supply side so that people do not have these financial barriers to accessing care. And then when they get to the facilities to access care, they can actually get the quality health care that will make them to have the outcome that they deserve. I'd like to stop here for now.
Thank you very much, Dr. Ilika. Thank you. That was very comprehensive. And like you, I find the fact that a woman can't access care. I mean, I'm a pediatrician. A child comes in and you're asking the mother, why have you kept the child at home for so long? And she says her husband is not around, or her husband hasn't allowed her to bring the child to hospital, or the mother-in-law said they should do this. So I think, as well as all the things listed off, there has to be empowerment for women as well, so that they can look after themselves and do that which is right. But instead of talking, let me ask Dr. Jorai to please weigh in on this. Where do you think we are at the moment, and what are some of the issues that are challenging and facing our women at this point in time? Anything else to add to what has already been said?
Thank you very much for having me. Good morning to everyone, and for those that are joining from outside Nigeria, if any, good afternoon and good evening. I'm quite excited to be, a part of this very important webinar in my view, because we're talking about maternal health. And for anyone that knows me, maternal health, health of women, and the overall well-being of girls and women actually is what I have been working for almost all my adult life. And so I know a lot has been said by the past two panelists, but I just also want to add my voice a bit towards the issues about maternal health and why we are, how we are, where we are, and so on and so forth. But just generally, I think improving maternal health is very critical to saving lives of women and also the entire population. We know that one of the major challenges of maternal health is that maternal mortality, over 90% of the causes of maternal mortality are actually preventable. And we know that developing countries like Nigeria, as the other panelists have also said, is that Nigeria accounts for most of the maternal mortality numbers in across the world. So there's a lot that we need to do, and we need to think of as a nation. And for us that are working in the health space, there's a lot that we should bring to the table. For instance, I would like to talk more about a bit more about the causes and why we are where we are. There are many factors associated with maternal and reproductive health situation in the country, and I would like to just put them into these three buckets of the three delays, so that we can help explain the barriers to timely care, and these actually contribute to the high maternal mortality that we record in the country. And the first is delay in seeking care. The second delay is actually delay in reaching an adequate healthcare facility. And then the third delay is delay in receiving adequate or quality care at the facility level. The other two panelists and the moderator have talked a little bit about these as well, but I just thought to put them in these three buckets. And as reflected in these three delay model, delays in saving life occur at different levels. At the individual level, looking at even reaching the health facility itself, and then or even deciding to seek healthcare, and then delay. We have also community level factors, those that affect delay in reaching in the health facility, and then we have the facility level factors. So basically, maternal health is a systemic problem that if we do not address the health system as a whole, and I like the fact that Francis talked about the primary healthcare system, I don't think we will be, addressing the issues. And again, I also want us to look at the social determinants of health very critically, because maternal health is not all about, the health system, but it's about the general social system and the communities and the whole environment that we live in. For instance, at the individual level, one of the major causes of the high maternal health indices that we have, or maternal mortality indices that we have, is lack of education. Many of our young girls are not educated, even up to secondary care level, so they don't have the awareness to be able to know, the information regarding their healthcare and those of their children. Then we also have empowerment and agency of the girl and the woman, and that's where poverty comes in. Many of our women and young girls, especially in rural areas, do not have the 7,000 naira that we're talking about to be enrolled in the health insurance schemes. At the community level, generally, gender inequity, I need to bring this up because, most of the challenges that we have that cause these poor maternal health indices are related to the gender inequity. And one of the panelists even said it, and I think it's the moderator, that, you can see a woman or a girl sometimes not being able to access a facility when she's in need, just because her husband or her father or a male that is in the family is not around to give her the permission. So these kind of issues really affect, and continue to, make the maternal mortality indices remain high. The general empowerment of women and all. And then at the facility level, Dr. Francis has already mentioned many of these, shortage of commodities, the infrastructure. Unfortunately, a lot of our primary healthcare facilities do not have the infrastructure that is required to provide minimum standards of the quality of care that is needed. Trained health workers, the doctor population ratio is very low. Even the doctor-nurse nurse-patient ratio as well. We have a lot of community health workers that may not have the competency to man primary healthcare facilities, but unfortunately, they are the ones that are in the primary health centers at the moment. And so we need to look at it as a holistic level, both the health system itself and as well as other social determinants of health. Even housing is another big issue. Education, as I always keep on saying, is one critical impact that has an impact of a factor that has an impact on the maternal health in Nigeria. So I'll just leave it at that and then allow others to talk. Thank you.
Thank you very much, Dr. Amina Jawai. Thank you. That was a good recap and summary of everything. I particularly like the three delays, and it just summarizes everything completely as to why we're here at this time in our history in Nigeria. The next thing I'd like us to look at is, what is universal health coverage? And once again, where are we in this? There are pockets everywhere. I know in Lagos State, we have started the Lagos State Health Insurance Scheme, and there's a National Health Insurance Scheme. And it seems as if where Dr. Onya has her primary health care in Delta State, there's a compulsory health insurance scheme. What are your opinions and what are your experiences? I'll start with you, Dr. Dorei. What's your experience with universal health coverage and insurance schemes? Yeah.
Okay, thank you very much. And I think this is a very critical question because, to achieve universal health coverage, in Nigeria, we really need to reorganize our healthcare system, in a way that provides, as everyone has said, specific healthcare benefit package, to everyone without financial risks, and to ensure that everyone is protected. Over time, I've seen that Nigeria's main strategic mechanism actually for achieving universal health coverage is the National Health Insurance Scheme, as we all said, and also the corresponding state insurance schemes. And this contributory, social health insurance scheme, for me, the National Health Insurance Scheme that was launched since 2005, we are really, way behind because up till today, up to 80% of Nigerians are still not covered by the scheme. We have the state health insurance schemes that even before the policy was in place, there were a lot of challenges of people understanding what the health insurance scheme was, and even the communities agreeing to be part of the scheme because, over time, there has been a lot of mistrust in the health system. So for those are even for the formal for the formal workers that, the government can remove, this, their money from their salaries. So even for the formal workers, they are yet to even believe and trust the system, not to talk of the informal, community members, which are even, more in our community. So in my view, achieving universal health coverage is very critical to improving the healthcare of women and, also reducing the maternal mortality because, it will ensure that every woman of reproductive age, gets the appropriate quality of care that they deserve and without payment, because we've been talking about, poverty as one of the major causes of maternal mortality of the, poor health indices that we have. And so if we're able to remove, that particular challenge of paying at the point of care, especially in emergencies, we will definitely try to, achieve health outcomes, So, for me, I think there's been a lot that have been going on in Nigeria in terms of the policies and the procedures, Safe Motherhood Initiative, the primary healthcare scheme, the family support programs, and the prevention of maternal to child transmission of HIV, and also the National Strategic Health Development Plans. All these are available, but without having a strong universal healthcare system, I think none of these would be achieved. So I'll leave it at that to allow others to also talk. Thank you.
Thank you very much. Thank you. Dr. Elika, do you want to weigh in with the experience so far with regards to universal health coverage?
Yes, thank you very much for the question. So UHC happens to be a passion of mine. And it's a place where I've done a lot of work in the past decade, if I may say. So, I would like us to remember the key goals of universal health coverage, which is one of them is universal access. What this means is that everybody, no matter where they are, can have access to the healthcare that they need, wherever they need it. So access should be based on need, not on ability to pay. So, some people have spoken about women who are not even able to pay 7,000 or 12,000 or 10,000 as the case may be, depending on the state where they are in. So it's very important for us to understand that access to care should be based on need, not based on ability to pay or ability to contribute. Now, the second bit of it is quality. So making sure that the healthcare that they are receiving is of adequate quality, so that their outcomes can be improved. It's very important, to note that while we're talking about quality of care, that quality of care is related to outcomes. So if a woman is pregnant and she goes into the health facility to access care, we want her to be able to have a safe pregnancy, safe delivery, and be able to go home with her baby healthy and the woman healthy. And then the third part of it is talking about financial protection. So those financial barriers that prevent women from accessing care. And I really love that Dr. Amina spoke to, the social determinants of health and some of the things that are presenting financial barriers to women accessing health, including cultural, behavioral, financial education, economic empowerment, and all those things that are presenting financial barriers to women accessing care. And then perhaps my favorite part of it all is the equity bit of it. So equity is talking about everybody, no matter who they are. I love to explain equity using, layman's terms to say that equity doesn't mean that we should all go and stay in maybe my colleagues who work in the hospital, they have the priority wards where the rich people stay and all that. That's not what we mean when we're talking about equity. When we're talking about equity, we mean that a very rich woman, for instance, say who heads a big organization is pregnant and she goes to the healthcare facility and she gets the healthcare that she needs, quality healthcare, she delivers, she has a safe baby, she and her baby goes home safely without any problems. A poor woman who is uneducated, who has no job in the most remote village in whatever part of Nigeria, be it Northeast, even in places where they have wars, should also be able to have the same privileges. She should also be able to walk into a healthcare facility, get good quality healthcare. It may not be in the amenity ward or the well-furnished ward, but she should be able to get quality healthcare, be able to have a safe pregnancy, safe delivery, and be able to go home with her baby safe and the mother safe as well. So that's what we mean when we're talking about equity, access to care being based on need, people getting the healthcare that they need so that they can have the best outcomes, irrespective of where they come from, their level of education, what they look like, where they live, whether they have a job or not, whether they are married or not, how old they are, irrespective of their demographics or their socioeconomic status or their situation in life, women being able to get the reproductive, maternal, and child health care that they need when they need it, and promptly enough for them to have very good outcomes. Now, it's on that background, of understanding UHC that we would like to address the issues that we have in the country currently. So based on the WHO, World Bank, and Universal UHC indices, Nigeria is not doing so well. So for instance, we still have over 70% of our payments through out of pocket, as against the benchmark of less than 30%. Now, another very important aspect of UHC, or one indices that is used to measure or UHC, is how much is the government spending on health. So we're all aware that in Nigeria, there was an Abuja declaration and a target was set for 15%. Some other countries that were part of this meeting, have reached that, but Nigeria is still, I think our current 2022 budget is still putting health, percentage of the budget allocated to health at about 5 to 6%. So we're still a very long way from the 15%. And then another indices I may also, another parameter I may like to cite is with regards to government health expenditure. So how much is the government spending per capita? The recommended is at least $86. Nigeria is still at $12 per capita, a very far cry from what we should be spending. Now, why am I talking about government spending? Government spending is very important because we live in a country where almost half of the population can be classified as poor. So they're not able, to pay to access healthcare. So there must be a mechanism for government to fund the healthcare. So when we're talking about health financing, we're talking about adequate financing. We want to make sure that we're spending enough on healthcare, but we also want to make sure that the amount that we're spending it well. So for instance, to put this in perspective, if we're looking at the general expenditure on health, including both from government and households and all of that, it's about $76 per capita, which is closer to the $86. But what this means is that the bulk of the spending is coming from households. And I'm sure you realize the inequity there, because what it means is that it is only people who can afford to pay that can access healthcare. And where do we have the bulk of the maternal mortality and the illness and all of that? Among the poor. So if we continue to finance our health system the way we've been going, we're going to keep having these very bad indices. So we need to look at it from two aspects. First, making sure that we're spending enough on health, but also making sure that we're doing it the right way. How are we financing our health system? And that brings me to some of the reforms that are currently in place. One of them is the state decentralization of health insurance. So like Dr. Amina mentioned, Nigeria has been running the National Health Insurance Scheme, started at the same time as Ghana. Ghana has reached over 45% population coverage, but we're still at, many people will put it at different places, 5%, less than 10%, depending on who you're speaking to. Now, one of the reasons why we've not made considerable progress is because Nigeria runs a very complex federal system. I'm sure we're aware of that. So states have the right to set their own health agenda and to put things in place and to make their own health decisions. So when Nigeria tried to run the health insurance scheme as a national health scheme, like Ghana did and some other countries did, it was not successful. So in 2015, the National Council on Health, which is the highest decision-making for health, decided to decentralize health insurance. It's often difficult to explain this, to people when you leave the country, but within the country, we understand why this needed to happen because the states were not, joining the National Health Insurance Scheme. So this decentralization was meant to push the needle and make us to move faster so that the different states will be able to set up their own state health insurance scheme and then begin to enroll their population. And then, of course, we're aware that some states have done better than others, like Delta, Lagos State, Anambra, Osun State. Those are the states, some of the states, of course, other states as well that are moving very fast. But we also have some states that don't even have an agency. They haven't even started, right? So those, variations exist across the country. But even among the states that have started, they're still encountering a lot of challenges. And I would explain. So one of the mechanisms that have been put in place for financing the state health insurance scheme is that there'll be a pooling of funds from different mechanisms, right? So there'll be payroll deduction for civil servants, which is usually about 2% of the population, so not a lot, but it often helps to, kickstart the health insurance scheme. And then there is the equity fund. So most of the states have put in place that 1% of the budget or the consolidated revenue of the state should go towards the health insurance scheme as equity fund to provide health insurance coverage for poor and vulnerable people who cannot pay. Why this is important is that even though many of the laws are saying that it is compulsory for people to enroll into health insurance, if someone doesn't have money, how do you compel that person to enroll into health insurance? So that is why compulsory participation has to come with government subsidization. And it is this government subsidization that the National Health Insurance Scheme partners working in the space have been able to try to push. And many of the states have successfully, like Dr. Onyia said, we must also celebrate the successes, have also successfully put this 1% into the laws that establish the state health insurance scheme for many of the states. Right now, as we speak, only very few states have been able to access their equity fund. So a lot of work also needs to happen in that regard so that the poor and vulnerable people can be covered. Now, the biggest elephants in the room are the people we call the missing middle, the informal sector non-poor. So these are the people that have the shops in the markets, that have the firms, that have, they do jobs, they have informal jobs. Nobody knows how much they earn and all of that, but they can afford to contribute. And the way that the system is built is that they should contribute, the 7,000s, the 12,000s, the 10,000s. But how do we crack that? How do we get this informal sector non-poor to contribute towards health insurance? Because the way that health insurance works, social health insurance works, is that there is strength in numbers. So the more people that are able to enroll, the more the financial viability of the scheme, the more they are also able to cover more of the poor and vulnerable population. So very important policy, which I may want to mention very quickly, is the Basic Healthcare Provision Fund. So this is a way that the government put in place to make sure that there was financing coming from the federal level to complement the financing at the state level. So this stems from 1% of the consolidated revenue of the Federation of Nigeria. And it should go through state health insurance schemes, through the National Health Insurance Gateway, as well as state's primary healthcare agencies through the National Primary Health Care Agency Gateway. 50% is supposed to go through health insurance, 45% through primary healthcare, and 5% for emergency services. Many states have been able to access this, but as I speak to you, there are still some states that have not really been able to draw down these funds down to the facility level. And the primary healthcare bit of this is supposed to make sure that they draw down this 45% down to the facility level to provide some basic drugs, infrastructure, equipment. I've actually seen the effects that this could have, for instance, in a state like Osun State, where my project was privileged to support. So we actually saw primary healthcare facilities that hadn't gotten funding in a long time draw down this funding from the national level, and they were able to buy essential equipment, repair leaking roofs, reinstall water systems, buy labor beds, and things like that. And the effect was amazing and outstanding in the community, with people being able to access healthcare in this primary healthcare facilities that were not being they were not functioning properly before now. So Nigeria has excellent policies in place, but we need to implement at scale. Sorry if I took a bit of the time.
Thank you very much, Dr. Elika. Obviously, this is something you're very passionate about, and you've worked a lot on it. And I particularly like the last bit you said, that Nigeria has a lot of excellent policies. Implementation is the problem. And that is actually the problem, because we know it all and we know what to do, but why don't we do what we ought to do? So I'll go on to Dr. Onyia. How can we ensure that universal health coverage comes to being what it should be, and we can move maternal health and child health forward so that people don't die needlessly. And from what Dr. Ilika had said and what has been shared here already, the problem is the financing more than anything else. The government not doing their part as should, and people not being able to afford it, and that. So how can we move it all forward and merge it together so that mothers don't die needlessly, and being a pediatrician, children too don't die needlessly? Dr. Onya, you are muted.
Okay, thank you very much. After Dr. Ilika and Dr. Dorayi, I wonder what I would say as a clinician. They are the ones who work in the public sector, in the policy sector. And I think that's probably the most important. But like Dr. Ilika said, we have the policies. How do we implement? Who are the people who are to implement these policies? Nigerians. We are the ones. So sometimes it's not even about drawing down on the funds. It's about drawing down on the funds and using the funds for what they're meant for. That doesn't always happen. So maybe the first step would be for everybody to make sure that they get their PVC. Can we start with that? And that we vote good government into place at all levels, local, states, and federal. I think so. It starts with good government. And I think, because to be honest, like you said, we know it all. We have all the right policies. I can imagine if everything Dr. Ilika said has been, implemented, Nigeria will be at a different level. So what else is there? The funds are there. We have the budget every year. 1% of that budget should be the equity fund. So let's implement. So let's pray. Let's vote for good government. I can't think of anything else to say. But just one more thing I will add, from the perspective of a clinician. I remember when I was in medical school, they said 3 grave ills. So it's poverty, disease, and ignorance. And I remember my primary health, was called a public health teacher, I've forgotten what we called it, the PSM teacher, said of the 3 ills, the worst is ignorance. So it comes again to enlightenment, education. Because I work in the private sector and I work in Victoria Island, so where the supposedly most enlightened and wealthy Nigerians live. The honest truth is that the health-seeking behavior of many Nigerians, including the enlightened ones, is poor. And I think we need to address that. People will not seek help. So we talked about the 3 Ds. I like that. Even people who can afford it and who live next to the hospital will not make up their minds to go to hospital until they are very ill. That was very evident during the COVID pandemic, and responsible for quite a few of the deaths, And I think it cuts across all illnesses too, including the maternal health. The second thing is the issue of, again, faith and religion. There seems to be some pride in saying I had a vaginal, what they would call normal delivery. And, it's almost like a sin in some circles to have had a cesarean section, and your testimony is not complete if there had to be intervention. And these things also lead to maternal death, and they lead to, infant neonatal mortality, perinatal mortality. So we need to deal with those kind of mindsets and change them. I was listening to Sky News yesterday evening, and it was interesting that there's some kind of inquiry going on in the UK about maternal deaths, and to do with midwives delivering in the community and people coming to hospitals. So even in the UK, people want to do natural birth. What is unnatural about a cesarean section? What matters is that the mother is alive at the end and the baby is alive, and a good quality baby, not a baby who's brain damaged from prolonged labor. So I think, again, the issue of advocacy, the issue of enlightenment, and so on, even using our places of worship to let people know that there's nothing shameful, nothing wrong with having a baby, having assisted delivery. I think these are the 2 things I can add. After the gurus have spoken, what am I to add to it? All I know is to look after patients in hospitals. Okay.
Thank you very much, Dr. Onya. Like you, like me too, all I do is look after patients. But I'm glad we have expert planners that make policies, and I'm hoping to move the country forward. And like you rightly said, Dr. Onya, a lot has to do with good governance. If we had good governance, all the things Dr. Eleka had said, it's all there. There are good policies. Why can't we implement them? Why can't we implement them? Why can't we move forward like any other countries moving forward? But let's celebrate our little wins and just hope to move forward. You seem to have something to say, Dr. Joy. Did you want to add something to what is being said?
Yes, thank you very much for that opportunity. I think, you know, Dr. Onya touched on something that I really think is part of what I wanted to say, you know, in the next discussion or the next round, but I think it's better to say it now for want of time. You know, I think over time we have really learned what to do and what not to do in designing, you know, health programs generally, and, you know, specifically here for maternal health programs. And I like the fact that Dr. Elika has said a lot about, the health financing part of it. But one of the lessons really I've learned over time in doing this work, and Dr. Onya made me just realize that I need to say it now, is that the saying that nothing for us without us is very critical. And what I mean is that in designing maternal health programs, you know, we require women at the decision-making table. We need a shift in the way we do things, you know, and get more women in policy making, in executive positions, and even in the development sector as well, where we all are. We saw recently how, you know, the gender bills, unfortunately, were kicked out, you know, in the last 1-2 months. And this has been a really big issue for many of us, because we know that these gender bills are supposed to be the cornerstone of development generally, which includes health. You know, so I believe that I agree with Dr. Onya about the PVC, but I also think that women should actually pull themselves forward to be, you know, decision makers, because we have what it takes. There are many, we're all in this panel now, we're all, you know, strong women that are on the panel. And I think they have a huge role to play. And again, you know, one of the things I have seen is also that there's need to better address maternal health in a holistic manner. For instance, now we have seen that majority of the key causes of maternal mortality are really the social determinants and other factors like poverty, which is also one of the social determinants of health. And we have seen that there's a lot of, most of these causes are preventable actually. So I think it's high time that we address healthcare and maternal healthcare, for instance, as a whole. We need to strengthen the health system. So primary healthcare is very important, but, you know, we also need to find better ways of doing it. I was excited that I was part of the launch of the Lancet, I think this March actually, and it really gave us a lot of you know, factors to think about or elements to think about of the Nigerian health situation, which we all know. But I agree with Francis that it's not about the policies, it's not about the very beautiful acts that we have. The National Health Act is there. If we implement it as, you know, the way that we're supposed to implement it to the letter, I think we will be able to meet up all our health indices. But again, I would say that more women, getting more women at the decision-making table, ensuring that we support more women to, you know, be part of the whole development agenda is very critical. So I would encourage that as well. Thank you.
Thank you very much, Dr. Joy. That was, in fact, what I was actually going to ask next is how do we design better healthcare programs? And you have started by saying something, but I just want to read something from the chat, which I think is relevant here. Ijeoma Ezeome said that she agrees that we should start by voting a good government. However, from experience, we know that as soon as we vote in our politicians who we think are good for change for the worse and become untrustworthy, the populace does not trust the government. And so they are not willing to contribute, especially if they are not government employees. Meanwhile, a higher percentage of Nigerians are employed in informal sector, traders, artisans. And I think Dr. Ilika had mentioned that. How do we capture those people that actually have the money, but are not willing to? Dr. Onyatu alleged to the fact that we have a poor health-seeking behavior. And if even at that level, the Victoria Islands, the highbrow people have poor health-seeking behavior, and then we have all these faith-based and spiritual and all sorts of things, factors in, where do we start? Where do we start? Who wants to take that up? Dr. Ilika?
Yes, thank you very much. So it is $1 million question, right? And the response or the right approach to this is going to be multi-sectoral. It needs to be inclusive, and it needs to be culturally context specific, and it needs to speak to our reality. So I think one of the issues that we're having with regards to what I like to call the missing middle, who are the informal sector non-poor for many populations or many states, it might even be up to 70 to 90% of the population. One of the issues that we have with them is that it is a developing country issue. Developed countries don't have that issue because they are very formalized. So the ideal, which is what WHO proposes and all of that, is to have a general taxation system where the government is able to use taxes, and just like what happens in the UK, through the NHS in Canada, in France, and all of that, to just use general taxation and just give everybody healthcare, right? But because we're in a developing country, which is the case in many low and middle income countries, the government is not even able to collect enough tax. So for instance, in Nigeria, percentage of tax that the government is able to collect out of the GDP is just about 6%. You could compare this to other developed countries where they have over 30, 40%, of GDP as tax. So before we get there, how do we crack this missing middle, this large informal sector? How do we get them to contribute? And the response is going to be homegrown. So I think where we've got it wrong all this while is that we're waiting for Western solution to our local problem. And it's not going to come. It's not going to come from Westerners, it's going to come from us. Because we are the people that understand the way things work in these settings. We're the people that understand how large informal sector groups work. So the think tanks, the enlightened people, the experts in Africa, low and middle income countries must crack their brains, sit together, apply our context in an inclusive manner, like you mentioned, bringing the different parties together, the beneficiaries, the communities, the civil society, healthcare providers, traditional leaders, religious leaders, cultural, leaders. Everybody must come to the drawing table, and we must find this answer from within ourselves. It's not going to come from the West. I think for me, that realization is perhaps the most important bit of it when we're talking about how to crack this informal sector non-poor. Now, some of the other things that are very important is that it's become quite obvious that these problems are multifactorial. So there are behavioral issues there are cultural and religious issues there. And then, of course, there are health systems issues, which focuses on financing, governance, and all of that. So we must have a holistic approach that incorporates these different aspects to why women are not getting the essential healthcare that they need. So with regards to the cultural, the behavioral issues and all of that, the people who work in the health facilities, they have a lot of insights into that. When it comes to cultural, religious, and all of that, Dr. Amina is quite an expert. So I'll probably, and I know she'll have a lot of excellent ideas about, how do we crack these cultural and religious practices, and the time I worked in the clinics, of course, we were able to see that. You would see a woman who is about to die, but because the pastor said you have to deliver like a Hebrew woman, or you can't have a CS, she's ready to die, And then there are also cultural, I think one of the things I would like to highlight before I end is that sometimes these cultural issues and financial issues could be linked. And I would like to tell a very quick story. So providing support somewhere in the Southeast, we trained some traditional birth attendants to be able to provide care to women, because women prefer to go to the traditional birth attendants because mother-in-law says, oh, I delivered at a traditional birth attendant, why are you going to a hospital? So one of the things that we did was that we trained these traditional birth attendants to identify high-risk pregnancies and link them to healthcare facilities so that they can get the good healthcare that they needed. And this worked. So this woman went to a traditional birth attendant. She was going there for ANC, and then the traditional birth attendant said, this is a high risk pregnancy. I can't deliver you here. You could lose your baby or lose your life. I want you to go deliver at a hospital. And the woman agreed. When she got home, she told her husband said, if you ever step into that hospital, don't bother coming back to this house. And so, of course, only we as Africans understand these issues. Right? So the woman chose to preserve her home and her family because of the cultural issues around stigma and shame of being driven away from her husband's house. She was putting her life at risk, and deciding to deliver at this TBA, despite knowing that her life was going to be in danger. So once we got light of this, of course, we went there, we engaged the husband and all of that. And then the husband said, oh, my word is final. She's not going to any facility. But then I pulled him aside and I had this conversation with him and I said, I know you don't hate your wife. I know you don't want her to die. So what is the issue here? And then this man, close to tears, actually confided in me that he does not have any money to give this woman to go to the hospital. And as an African man, he has his dignity. And if the woman goes to the hospital and people hear that she's there and she didn't have money to pay and all that, it would be very shameful for him. And that is why, and that he doesn't have any problem with the woman going to the hospital. So we're able to link this woman to a financial protection mechanism through a faith-based, health insurance scheme that covered her antenatal care. And this was just one maternal mortality that was averted. You could imagine the thousands that are out there. So sometimes these things are linked. But also, I've also gone somewhere, in the northern part of the country where we were told that even if you remove all these financial barriers, women will still not go to the health care facility to seek skilled care. And I would like to listen to Dr. Amina's perspective, on that, about, what are some of these other cultural barriers that even with financial protection provided, people are still not seeking the healthcare that they need. So maybe perhaps I'll stop here and then listen to what other people have to say.
Thank you very much, Dr. Lika. Before Dr. Amina responds, I'd like to say, if anybody has any questions, they should please put it on the chat or raise their hand so that we can get them to ask their questions. So Dr. Amina, what other cultural barriers are we looking at, even if there's money? Are there other things that we should be thinking of now?
Yeah, thank you very much. And thanks, Dr. Elika, for providing this very detailed overview of these challenges. And I think what I would want to add here is that, I think these challenges, have two faces to it. There's the cultural arm, and also there's the government, and also, not really government, or rather, the laws of the land. Why a lot of things are going without anybody challenging it is because the laws of the land does not also protect women as per se. For instance, we know that even without financial hardships, one of the major issues that we have is that it is men that are at the helm of affairs in the religious sector in this country. If men were delivering, or rather were getting pregnant and were delivering and were dying, I tell you, all the religions would say that you must go to hospital, you must access care, because we know that when you're not there, that's why I said nothing without us, nothing for us without us. If women are able to even reach the pulpit, and talk more about their own gender, because they know what they feel, we would have a better, general system to support and protect women. That is on the one hand. Then on the other hand is the community or education piece. A lot of us don't really understand our religions. We think we do understand the religion, but we really don't understand the religion. We tend to listen only to what the imams or the pastors have said. We do not read widely because we think that whatever they say is the true situation. By the time that women read widely and are able to understand the real, laws of the religion, I think there's also a lot that can be improved that way, because you can be able to stand up to the religious leader and give your own verses to, show how to counteract what they say, especially related to your health and rights. So, and another area that I want to come out is that do want to, say more about is, sometimes, women are also women's problem. What the story that Dr. Elika mentioned just now about the mother-in-law being the one that will stand by and say, no, I would not allow, my daughter-in-law to go to a hospital, even though there was issue about, the man not having the funds. But the community uses women sometimes to also, affect other women's health. So I think one is there must be laws, and these laws must be enacted, and they must also, those that, go against the law should be punished. For instance, if we say every woman should go to a hospital to deliver, I don't think the government will be wrong in that, because you see, this is not a family issue. It's actually a community and a health system issue. And if we have, the more deaths we have, the more it will impact not only on the health system, but also on the economy, because it means that half of the population are always put at the danger zone, and they will not be able to deliver and support the remaining half, or the men that are out there. So I think for me, I will look at it in many ways. One is just what I said earlier about women being at the decision-making table, women learning more about their religion and their culture, and being able to stand up to the men and to those that, try to propagate these negative gender attitudes and negative gender norms that we still have in our communities. And then the second thing is women themselves need to be more friendly to other women, need to be more supportive to other women. If you're a mother-in-law, if you have powers, you should use it, positively. It doesn't mean that because I, during my time, delivered at home, and during my time, having 7 to 10 children is the norm. And if we do not do that, we'll be seen as less of a woman. It doesn't mean that if my daughter-in-law now decides with her husband that they want to have 2 children, 3 children, 4 children, that I should come to know it's their life. So there's a lot, around this that is beyond the health system, as I always say. But ultimately, the government has a role to play in putting policies and laws in place, and also trying to address those that do not, meet those policies. So these are some of the things that I could maybe add. Thank you.
Thank you very much, Dr. Amina Jawai. Thank you. What I hear you say repeatedly is that women have to be in the helm of affairs. They have to be where the decisions are being made. Because if, like you rightly said, if men are as affected, things would have changed a long time ago. But because women are not there, and they're not there where they're making decisions, we're where we are today. We also have to have good governance, homegrown solutions for Nigerian problems, educating our women, educating the populace generally, empowerment of women, and the like. We have some things on the chat that I'll just like to read. Ijeoma said that in addition to the pastor's watch, we have the problem of women's subjugation in Africa. Even when the man has money, his belief system keeps the woman down. And then Mrs. Ogunyemi said, well said, change of mindset is needed. We cannot even get women to key into the health insurance scheme, as we have said. Government needs to increase the health budget, and also more awareness about the need for preventive behaviors. Cultural and religious issues have serious impact on healthcare. Health also involves environmental issues, transportation, the economy, etc. So the government needs to step up. Health policies must be created, policies are law. And Okegene Owugo said, from the experience in Delta State's contributory health scheme in a remote riverine community in Delta State, a well-structured and precise information dissemination to rural women that accommodates peculiar rural understanding can lead to positive outcomes. Inadequate and wrong information made available to them has been found to be more significant than lack of money. And that's in support of everything that has been said here today. So one last question before we close this, and if anybody has anything else to say. We're all women in healthcare. How can we get up there and make all the policies that will benefit us? How can we be heard even better than we are being heard now? I don't know who wants to start with that. Dr. Onya, do you want to take that? Women in healthcare, what roles can we play?
Well, maybe a starting point. We already have there's a troubling video that's showing, I don't know, from Elizabeth Essien, I don't know what that's about, but okay. Anyway, I think the first thing that we do have a platform in the Medical Women Association of Nigeria. Maybe we should become actively involved. To be honest, I don't participate, but maybe that is like a platform we can use to have a louder voice as women. We have to find a channel through which we can be heard. And maybe it's time for us to resuscitate the Medical Women Association of Nigeria to beyond just a nice gathering of women periodically, but to become a real pressure group that it ought to be. That's the only thing I can think of. I can't think of any other way, because every other association will also have men, and it's often difficult for women to get their voices heard in groups where you have men as well. Otherwise, like me, you'll be considered aggressive when you try to have a very loud. but maybe when we I mean our home base is the Medical Women Association of Nigeria. So maybe it's a time for us all to get more actively involved.
Thank you, and I agree with that. I think if we have a platform like that, which is already in existence, but we need to do a bit more and ensure that our voices are heard so that all these policies can start benefiting women as they should. Dr. Ilaka, do you have any suggestions as to how we can get more women's voices to be heard?
Thank you very much. So I think that women can play a lot of role in this, as well as men. We live in a patriarchal society. It's not ideal, but while we're still on the journey, towards women empowerment, towards gender equality, equity, and all of that, which is the ideal thing, we must also engage the men. And my experience, both when I was working at the hospital as well as in public health practices, that a lot of the patriarchal rules are made by men. But you find sometimes people also say that women are the ones who serve as gatekeepers, who enforce it and tell other women what they can do and all of that. So I think both genders need to come together, right? And then the way that we engage men is also very important. So my project, Health Policy Plus project, in agreement with what Dr. Amina said, we try to do an analysis, a gender and equity analysis of some of these health interventions in 4 states in Nigeria, Basic Healthcare Provision Fund, State Health Insurance Scheme. And what we found was that the people at the helm of affairs, the people that led the boards, the agencies, were mostly men. So it reflects the same thing that we're talking about, that when we have these men making decisions for women, they don't understand these things. So for instance, we found out that many of the men that we spoke to, because men traditionally oftentimes do not utilize primary healthcare facilities because they see it as women hospital or women's center. They don't know the state of affairs in those primary healthcare facilities. So how do we make sure that women are the ones who are there, at the boards implementing these policies to make sure that they represent the interest of women? Another angle we also looked at it is, can we also make male services available at these PHCs so that men can also go there and see the state of affairs there, so that they can also become a voice, for change about improving the quality of care at this PHC. So what I'm trying to buttress here is that we need to work with women, but we also need to work with men. My experience working with men is that most of the times, the average man hears women empowerment or equity, and he thinks that it means that their wives will now challenge them. So we need to come from that place of education. As we're educating the women, we also need to educate the men that while we're talking about, this gender equity, women being able to access care and all of that, is so that they would not die, or their children will not die, or they would end up having children who have neurological deficits and things like that. So making sure that people understand why we're saying what we're saying, and it's not just to challenge them or challenge their authority as men or as pastors or as religious bodies. My father taught me that you catch more flies with honey than with vinegar. So being able to package that message in a way that they understand why we are asking for these things and why we're making these demands is going to be essential. Now, coming from what women can do, I think that we need evidence generation, right? So a lot of the efforts, a lot of the progress that has been made so far has been with real-time evidence, like this evidence we generated from the gender analysis and all of that. We were able to use that to engage. And they brought in some women into the boards of these meetings. And of course, things improved after that to say, we don't have these women at this boards, we need them to be represented, because they have a role and all of that. And that led to action. So women can play a role, women in academia, women in policy, women in the hospitals. When we see these things in let's do the case studies, let's come up with evidence and package it in a way that it's understandable, both to women and to policymakers and men and all of that, and then use it to drive change. And then evidence-based advocacy, using this evidence to speak to the people that matter, using the bodies, like Dr. Onya mentioned, to drive change and to speak to other things. Then, of course, women must learn to be their sister's keeper. So we keep hearing brother's keeper. I think keeper needs to become a thing now, right? So we move away from where women see other women as rivals and, talk about challenge them. You have to do certain things, to show that you're a woman and all of that. We need to move away from that and move to a place where women begin to support other women, where women stop acting as gatekeepers to patriarchal rules, but rather actually, start putting enabling environment for other women to be able to thrive. And then, of course, the awareness creation, women can also play a lot of role in that, educating other women, supporting other women, telling them about what they need to do. And then we also need to identify innovative mechanisms to increase domestic financing of UHC reforms, and for want of time. And then, of course, finally, policy implementation. So women can play a role in, advocacy, citizens' voice and accountability through women groups, markets women and all of that, to hold the voices accountable. One of the things that women are known for is being able to speak truth to power. So let's use that, right? So women are the only ones, maybe because of the maternal instincts, maternal protective instincts, women are the only one that can stand up and talk to anybody the way it is without being scared when we're trying to protect the people that are dear to us. So let's draw on those our superpowers, to be able to push some of these interventions. Thank you.
Thank you very much, Dr. Ileka. Thank you. And women are actually very powerful. Even history tells us when you want change, get the women involved. I have some things on the chat before I go to Dr. Amina. Get involved in politics, according to Kemi Ogunyemi. Get involved in politics and governance and support each other. Women groups should lobby. And Dr. Ileka is on point. She also says, get your voters card and vote capable women. More women in legislative arm of government will push women's health agenda. Ijeoma also agrees with Dr. Ileka and says that women are used as gatekeepers in most of these decisions. Unfortunately, these women agree to act as such because they think they will be accepted by the males. Education of ourselves is very important. Amina Ahmed says that for us in Lagos, the PHCs have services also rendered to men. And there's a strong male involvement in the ward health committees and community development committees. So this helps a lot. So I suppose some states are better than others in moving forward. But women supporting women, women being empowered and empowering each other, and also helping each other to move along, I think is probably a way forward in this. What say you, Dr. Amina?
Thank you very much. I think a lot have been said. I'd like to look at it, maybe in small buckets. What role can women play, in accelerating UHC, in changing the norms, in improving health outcomes, especially for maternal health and child health? For me, let me look at it even from the family level. I think we have to agree that our generation is going to be the last generation to perpetuate all these negative gender norms in the communities. And that being said, we have boys, most of us have children that are both girls and boys. We need to start changing the narrative to recognize that we need to train our boys to know that, for instance, cooking is a life skill, is not a female skill. I have boys that are in university and they know that they shouldn't wait for a female to cook for them. They need to cook themselves. So some of these, norms are actually supposed to be addressed from the family level. And I think we as women, our generation, should decide that we need to train our boys differently, because if we do not train these boys differently, they are the same boys that will grow as men and will continue to sustain these patriarchal norms that we're talking about. So that is it at the family level. We also need to ensure that, for us, and also help our rural counterparts, the women counterparts, to recognize that education is not only for boys, it is for both males and females. And the way that, you encourage your children, your boy child to go to school, you have to encourage your girl child to also go to school to the last level of master's, of PhD or whatever, because that helps for her to have the agency and to have the knowledge and the skills to be able to resist some of these gender norms and the gender barriers, to know that she needs to go to a hospital to give birth, even if anybody else says that she shouldn't. And she has, understanding of what her rights are if she is well educated. So at that family level, boy child education and girl child education, and also trying to change the narrative so that boys can recognize that the roles that, they play are critical, and also they are, basically the same. There's that gender equity from the family level. Then we have the community level. And I know Dr. Elika talked a lot about the community level, how we as community leaders, in our various communities, people will listen to us. We have a role to play in sensitizing the public, both women, both men, and letting them understand the reasons why these things have to change. Because, if we use data, for instance, most of the communities may not even understand the data. So we have to have human angle stories to show them what is going on, with pictures, with, messaging, with IEC materials that they would understand. Because the truth is that most of the reasons why these norms continue to be sustained is because people do not know better. And so they think that they want to, protect their cultural heritage, whether they are positive or negative. But we as women in the health sector have a role to play in disseminating the right information. And at least we also need to understand our context as well. For instance, if Dr. Elika may be going to Enugu or I going to Kano, we definitely understand the context in both countries differently. So when we know that, we'll be able to respond to whatever they would say that will, hit the nail on the head. Because if, for instance, I go to, Calabar and start talking to them, they would think that I don't know much about their culture. So we need to be context specific. We need to address the issues with knowledge as well. We need to understand and know what the issues are in order to address the issues. Then, at the bigger level also, that is where the government and the policy making comes in. We should be, I like what Dr. Onya said about coming together. We need to form networks, not only the Medical Women Association of Nigeria. There are many networks, Women in Global Health, for instance, that we could use to really push our voice and talk, on radio, on TV, write everything. We need to have one voice, talk as one voice. And I like the fact that this webinar brought, the women together. So we need more of these webinars to talk and to bring people on the table, and not only to talk to ourselves, those that can afford to join webinars, but to go down to the communities to talk to people. Last but not the least is the trust in the government system. One of the major reasons why our people, especially the women, do not want to go to health facilities, because you see, a lot of them, for instance, would go to receive antenatal care, but when it comes to delivery, they will just stay back at home and take their delivery. Some of them feel that the health workers are not friendly, they will treat them, unfairly, and all, there are no commodities, or it's too expensive, or when they say it's free healthcare, it's not really free, so they have to pay. So they have an alternate, which is the TBAs and traditional means of medicine. We need to ensure that we standardize care, and laws have to be in place to address these community or traditional medicine that are in place, because they are doing really a lot of harm. But if we flip it on the other side, they could contribute to doing so much good by identifying, for instance, danger signs during pregnancy, and helping to refer and to bring women to health facilities. So because we have existing community-based systems, we should not only think of throwing that away because of our context, but how do we make use of it to actually incorporate it into our primary healthcare system? And so, make sure that everybody, is carried along. So for me, I think, and also as leaders for us, educate, in terms of encouraging more women to get into science, technology, engineering, and mathematics subjects, that's STEM subjects. And also, in our various jobs, give equal opportunities for girls or women in our jobs, give them the enabling environment to thrive, just like we have. There's a lot to say, but I think I should stop at that. Thank you.
Thank you very much, Dr. Jarai. Thank you. And that was good. And especially going back to the family level, what we saw in our children, especially our boys, is what is going to come out later. And I know that is a topic for another day, because it's a big one, parenting children and doing it right from the beginning. But also women supporting women groups, involving men in it from the beginning and all that. So thank you very much. I mean, it was comprehensive, and everybody has spoken extremely well with regards to this matter. Another matter that's maybe another day is the brain drain, because we do everything and put all these policies in place, and then you get to the hospital and there's nobody to see or nobody to give you quality care. And also task shifting. Maybe we need to train other people to do all the jobs that need to be done, like community extension workers and all those. So thank you very much, everybody, for all your contributions. I don't know whether we have any last words that anybody wants to say, burning issues that need to be talked about before we hand back over to the EDC team. Any last words, anybody?
Just something from me, two cheering things I heard from Dr. Amina. She says that this will probably be the last generation.
And I agree, yes.
I agree.
I agree, yes.
I think that's very cheering. And then the second was something Dr. Ilika said that has escaped me now, but I thought was also very impactful. And I think it's something for us to look forward to in the future, to say it's not as bad as it appears. If I remember before, I'm an old lady, if I remember before we closed down, I'll say the second thing, but I thought those were two cheering notes to depart on. Thank you. I remember
Thank you. Yes, yes. And I agree totally with Dr. Amina that this will probably be the last last generation of this. Because if you listen to the young girls nowadays, they are not taking any, they talk and they are very empowered, especially the educated ones. But I know that there are a lot more that are not educated. So we still have a long way to go, but we're getting to the end of it all. Any last words, Dr. Ilika, Dr. Amina, before I hand over to the EDC team?
Yes, so I think a lot of things have actually come out of these discussions, how we need to tackle it from the family perspective, from the individual awareness creation, understanding, from the health system strengthening perspective, from the community perspective. I also wanted to highlight the role that, community leaders have to play, civil society, CSOs, and these people who already know how to engage communities. They have a role to play here. And then also I had put something in the chat about women economic empowerment, right? So when I worked in the hospital, I've seen that, when it comes down to it and a woman's life, I've had women, who were waiting for their husbands to come back. And as soon as it became really bad, if they had some money in their pockets, they would take themselves to the hospital without waiting for their husbands to come back. So we cannot overemphasize the importance of a woman having a way to earn a living. But it also goes hand in hand with some cultural practices, just like Dr. Amina highlighted. So I've actually seen women who are trained as doctors and their husbands say, you shouldn't work, you should stay at home. So of what use is that education and economic empowerment if, we have cultural barriers in the way? So just to emphasize why this is requires a multi-sectoral approach. When you're talking about the SDGs, it cuts across at least half of the SDGs speak directly to the things that can actually improve women's maternal and child health, while the rest of it speak indirectly to it. So we must take that multi-sectoral approach, talking about poverty eradication, economic empowerment, gender equity, improving UHC. All the different parties that are involved in all of this must come to the drawing table. We must work together if we want to see a lasting impact. Thank you. And it's been great being part of this panel.
Thank you very much.
Thank you.
Thank you, Mom.
Yeah.
Thank you.
I just want to add one comment.
Yeah.
Yes. So we are getting very close to an election year, 2023. We need to use our powers as women, because women are those, those that out of the population that votes, I heard that women are the most in number of people that go out to vote. We need to have healthcare. Now is the time when the parties bring out their candidates after primaries, for instance. What is their agenda for health, and specifically, what is their agenda for women's health? We as a community, which I think we should be wiser by now, we should not just choose people just because they say they will be, our leaders. What agenda do they have for our healthcare? What agenda do they have for the women's health in general? And so we should utilize this 1 year, and I'm looking forward to it, to make it our business, because we are in the hospital or in the development sector, every decision that is taken at the governance or policy level would affect us. We have seen how it has, as I said earlier, the gender bills and how the primary healthcare bills and the universal health coverage, all these policies, bills and acts affect us directly. So women, I'm charging us that it must be our business. We need to put policy making and governance at the heart of affairs. We need to ensure that we bring, we make them accountable for any, element or any factor that we believe will affect our lives. So let's use this election year. Let's use it to ensure that we have a good agenda for maternal health before we go out there to vote for candidates. That goes for just not the federal level or national level, but we should also make sure we push that also at the state level and at the different local government levels as well. It's huge work, but it can be done, and we have nearly a year to do that. Thank you.
Thank you very much, Dr. Dwyer. And thank you to all the panelists. I'm highly honored and privileged to be on the platform with such powerful and knowledgeable women. So thank you very much. I'll now like to hand over to Dr. Njide Ndili, Country Manager of PharmAccess Foundation, to do her closing remarks. Thank you, everybody.
Well, thank you so much. This has been very, very informative. And just a correction, I'm not a doctor. They keep calling me a medical doctor. Sometimes I don't even bother correcting. I just assume the position, but without any disrespect to those that spent many, many years in medical school. You know, I think I know a lot, but, you know, each time I'm surprised at the wealth of information that is discussed. You know, you listen to all these women, the panelists, and it is just amazing. I am so thrilled. But then you wonder, I mean, with such powerful women in, you know, really strong positions, why are we not making a dent? I mean, we've been at this for so long. But anyway, not to be discouraged, because we have to keep pushing. One thing that stands out, I know Ngozi started with talking about the program which is running in Delta State. She didn't mention the fact that PharmAccess was actually the organization that came up with this framework. And why did we do that? It was because, you know, as you know, almost all the states in Nigeria have passed mandatory health insurance laws. But the traction, we're not seeing the traction, the number of people getting enrolled. And why is that? First of all, trust in the system, then the outlets where people need to go to access care. And as technical assistance partner to quite a number of states, we thought, well, how can we think outside the box, which is something we need to continue to do, to try things that have never been done before, to change, you know, or to remove obstacles. So fortunately, we had a forward-thinking DG in Delta State, and I see Clinton is on, who was willing to experiment with us. The government, as we know, is used to bricks and mortar, investing in physical infrastructure as a way to invest in healthcare. We've done that repeatedly year on year, and we're not seeing any change in maternal mortality or our indices. So the point was, how can we even experiment and see if there's another way to approach this, which is what led to the PPP at the primary healthcare level. That hadn't been done before. And it's amazing, the data that we're seeing. Dr. Nya talked about the numbers of babies. Only she herself is even delivering within her own facilities. Meanwhile, there are about 15 of them. And it's the same story in every single PHC that is being run by private sector. We're currently conducting an impact evaluation, which was requested by the Honorable Minister of Health, because I think these are some of the ideas that would change policy, to change the way things are done within the country. So again, I would urge those of us who are in positions of being able to implement something new and different, to document what you've done and find in forums like this to share those experiences so that we can replicate them across other states and help, you know, reduce or improve our indices. So having said that, I think that this is really fantastic to be part of this. If I look at the names of the participants, I saw a lot of women. And I can tell you that this is one of the lowest attendance we've had. And you can correct me, EDC. And I'm sure it's because it was focused on a women's topic. If it was something more general or something more towards men, I'm sure there'll be more attendance. So again, this shows the fact that women issues, even though it is so critical, is still not at the top of the agenda. And we need to come together to continue to push. And I'm willing, you know, hopefully with all the other strong women that have stayed on, to see what we can do to change the narrative. Again, thank you very much for your attendance, and we look forward to the next webinar. Back to you, EDC.
Thank you very much, Ma. Thank you very much for those words. Yes, you're very correct. This is the lowest we've had so far since we've been having webinars on the health platform. I don't want to believe it's because it's a women-centered kind of topic. Actually, we're actually celebrating International Women's Day. So I actually expected a lot of women to be on this platform today. But, you know, sometimes it happens this way. So I want to use this opportunity to let the House know that the Healthcare Management Program Cohort 8 already started on Monday, and there is still room for those that are interested to come to join the Healthcare Management Program. It's a community of health practitioners and enthusiasts. We are trying to change the narrative in the health sector. We are trying to build a consciousness where the business of healthcare is taken seriously, not looking at the professional aspect of healthcare delivery this time around, but actually looking at the business aspect of it, and then growing and enabling sustainable healthcare system or sector in Nigeria. So you can just buzz me up at my contacts on the, I have my phone number on the chat box. Just give me a call if you want to know more about the Healthcare Management Program. I'll be so happy to talk to you and also get you onboarded on the program. That's my contact detail on the chat box. So I want to say special thank you again to all the participants.
Can I just, I just got a chat from Dr. Ben, who is actually on the line. Dr. Ben is the DG of the Delta State Contributory Health Scheme that is in charge and pushing for that program that is running in Delta State that Dr. Onya mentioned about. And he wanted to make a brief comment. Dr. Ben, I'm glad there's a powerful man on here with these powerful women. I don't know if you're still on there, just to lend your quick voice, because you are making a lot of impact with this program in Delta State, improving women's health. Are you there?
Jide, yes, I am. I hope you can hear me.
Yes, we can.
Okay. Actually, the experience has been mind-boggling, because this was a community that hadn't gotten access to healthcare for over 20 years, despite having a built facility there. And so what I was trying to emphasize that it's not just about getting them health insurance. It's not just about making funds available. It's not even about getting facilities there. It's about what level of information do they have? What level of information do they have to be able to assess and benefit from the service? So they had a situation where a woman had come there and told that if you deliver and somebody sees you delivering, evil spirits will attack you. So every woman decided to deliver just that woman, and she was not skilled until this partnership came, and we're able to, in partnership with PharmAccess, get medical personnel there, get an equivalent old woman that was there to prove that this service could be done. So what I'm trying to emphasize is that proper information in the way they will understand is very, very crucial. Thank you.
Thank you for that, Dr. Ben. Again, just to hear directly from him, and this is just the tip of the iceberg as to what can happen when private sector partners with government and forward-thinking government. And if this is just one PHC, think about 30,000 PHCs across the entire country and the impact we could have with this kind of forward thinking. So thank you, Dr. Ben, and please keep preaching and leading the way for other states to follow. Back to you, Chinedu.
Thank you very much, ma'am. So it seems like Delta State is pioneering a lot of things. Even in the training of the business development service providers that is being championed by EDC and SMIDAN, Delta State government has also taken the lead by training over about 50 of their BDSPs. So which is a good one. Thank you, Dr. Ben, for helping us understand this. I hear from you directly from you. And on the good works you guys are doing at Delta State, please keep it up. So thank you very much, everyone. Thank you, the panelists, Dr. Ngozi Onya, Dr. Amina Minudorayi, Dr. Frances Ilika. Thank you for sharing your thoughts. But also special thank you to the driver of the conversations today, Dr. Abimbola Cecilia Mabugunje. We really appreciate your doggedness and how you actually drove this conversation this morning. We want to say thank you at PharmAccess for always collaborating with Enterprise Development Center in delivering good content in terms of business education, in terms of healthcare education to Nigerians. I want to say thank you very much, PharmAccess, for always supporting us. And we're also looking forward to the healthcare conference coming up in May. We believe that that's also going to be another very informative sessions that we'll be having under this platform. So for everyone that attended this webinar, those that registered, those that are physically present here, I want to say special thank you for your time, for staying all through the 1 hour, almost 2 hours now that we started this program. So I want to use the opportunity to say thank you and then have a pleasant weekend as we go into the weekend. As always, stay safe and continue to pray for Nigeria. Thank you.
Thank you very much and have a good weekend.